planning to do the osteotomy, measure the length, I overlap it over the line, and where it ends, that usually gives the approximate width of the correction. So theatre setup is very important. I do always do a diagnostic arthroscopy before surgery. So the arthroscopic console will be on the opposite side of the knee. The C-arm comes from the same side, and you should have a translucent bolster. And before you start the surgery, you should know that you should have enough space underneath for the C-arm to go from the hip all the way to the ankle. So you should make sure before you brace the patient that you are adequately able to visualize the hip, knee and the ankle. And this is also important when you are planning for additional ligament procedure along with an H-tube. So in diagnostic arthroscopy, so we just look for the cartilage, and it's very important to look in the lateral compartment if there is any cartilage damage. It may be missed in the MRI. If there is cartilage damage in the lateral compartment, then there is no point doing a high tibial osteotomy for the patient. So these are the basic instruments what you need. You need a good osteotomes, and there are sequential osteotomes with which you can open up the joint, and also need good retractors. And if you have a translucent retractor like they showed in the theatre, it's even more important to protect the vascular structures posterior. And now the various companies have come with various good dilators to open up the osteotomy site. So the incision is usually centered between the anterior tibial tuberosity and the posterior cortex. Usually you can make it at the center or slightly posterior. Usually anywhere from 5 to 6 centimeters incision more than enough. If you are planning for a ligament reconstruction, when you are doing it, you harvest the hamstring tendon also at that time. So then you identify the superficial MCL and erase the MCL from the medial tibial cortex, and you identify the posterior most cortex. Then with the periosteum, you elevate the MCL and also the posterior structures from the posterior cortex of the tibia. That is very important. You have spend some time to erase the MCL and also erase the posterior aspect of the cortex. So that in that way you get the adequate exposure for the posterior tibial cortex, and also you prevent any injury to the vascular structures. So once you plan for once you have done the adequate exposure, then you usually start by putting two guide wires like they showed in the theatre. It usually is about 4 to 5 centimeters from the joint line. It's better to have the osteotomy as proximal as possible in the metaphyseal area. The more the osteotomy is in the metaphyseal area, the healing is good and it's faster. And also, I usually don't prefer to bone graft the osteotomy site. So if it's more proximal, then it's good. But in cases where you want to do a ligament reconstruction, you may push the origin start of the osteotomy slightly lower. So if it is just an osteotomy, I start anywhere 4 centimeters from the joint line. If it is, I need to do an ACL reconstruction also along with that, I push the start of osteotomy slightly 1 centimeter lower. And you aim it to the tip of the lateral malleolus. Okay, like they showed in the theatre, you pass the parallel, two parallel wires. They showed this instrument, it's very useful. And also it's very important that this wire what you pass should be parallel to the slope. So we have to, the lateral axis, you should see what is the angle of the tibial slope, and based on that, this wire should be parallel to the tibial slope. Why it is important? So that in medial opening wedge high tibial osteotomy, there is always a risk that invariably will increase the slope. So if you are able to keep this wires parallel to your tibial slope, then you will be, the correction what you get, which I will show eventually, you know that you are not altered the tibial slope, or you are reduced the tibial slope. And it's also important to do the osteotomy distal to the wires. If the wires act as a protection from preventing the hinge fracture. You can prevent hinge fracture by passing osteotomy just distal to the wires, and also you can pass a hinge wire. Like Dr. Shreyas showed, you can pass in the lateral tibial cortex, you can pass a wire or a screw to prevent hinge fractures. And also you have to stop about 5 to 10 millimeters from the lateral cortex, osteotome from the lateral cortex, to prevent any fracture. Then you pass osteotomes serially into the osteotomy site and gradually open it. So we have to spend some time here and gradually open. You have to allow the bone to expand. So if you are hasty in this, you may cause inadvertent fracture or you may cause a hinge fracture. So you have to gradually and slowly open up the osteotomy site. Once you have done that, you can pass the wedge inside, place the wedge. You can use either one or two wedges to open up. If you are going to use only one wedge, place the wedge in the posterior aspect of the cortex so that it opens in the posterior aspect and the opening in the anterior aspect is less, so that the slope will be less. So once you have done that, you have got the pre-op correction what you have got. Then you check the correction by using either the alignment rod, or if you don't have the alignment rod, you can still use the diathermy cable. So preferably you should use an alignment rod. If not that, you can still use a diathermy and check whether we are passing what we wanted, either at the lateral edge of the tibial spine or in that Fujisawa point. Once you are happy with that, then you place the plate. The various companies have various different plates for us to use. So whichever suits us, we can use those plates. And it's very important to see that the opening in the anterior aspect of the osteotomy should be smaller than the opening in the posterior aspect. Only when you are doing a PCL reconstruction along with that, then you need more slope. All other cases, with just an isolated high tibial osteotomy, or you are doing an ACL along with that, you should have lesser slope. So another trick for getting the slope correct is you open the osteotomy in extension. Keep the leg in extension, don't keep any bolster under the osteotomy, and you keep the leg in extension. When you keep it on the bolster, it automatically hinges anteriorly and it closes the proximal aspect, opens the distal aspect. We keep the leg in extension. So you can see here, when you follow all these things, the slope remains unaltered or the slope is reduced. So when do you do associated ligament reconstruction along with osteo? When the patient has a chronic ACL insufficiency, if he has only instability and has no pain, you just do an ACL reconstruction. But if he has pain as well, then you go in and see what is the reason for his pain. You take an alignment X-ray and if there is a varus deformity, then you do a high tibial osteotomy. But in a middle aged patient who has an ACL deficient knee, but even though it's an ACL deficient knee, but he has symptoms are primarily due to early arthritis, then you don't need to do an ACL reconstruction along with that. Just a high tibial osteotomy alone is enough for him. So summarize. So if the patient has a grade 3 to 4 cartilage changes and ACL tab along with instability, then you do ACL reconstruction also. But if there is a varus but no instability at all, then just do an HTO. So like I said, like sir also said, if there is increased antitibial translation with an osteotomy, it puts undue stress on a reconstructed ACL graft. So all the more reason when you do an ACL reconstruction, it's very important not to increase the tibial slope. So tips while doing the ACL reconstruction, but after placing the plate, don't put the anterior screws. Keep the plate as posterior as possible. So when I do an ACL and HTO, along with it, I first finish the osteotomy, then I go for the ACL reconstruction. I don't put the anterior most screws, I leave that, and then make the tibial tunnel, and then pass a Wissinger rod or a alignment rod, a procar inside the tunnel, so that I know the orientation of the tunnel. Then I pass the drill. So and the good thing with certain place there, the screw hole is a variable angle. So in those things you can adjust around the tunnel and you can pass the screws. So and also once you pass the screws, you check with your camera inside the tunnel to see whether we are violated the tunnel or not. So this is one of the cases where he had both male compartment arthritis with ACL tear. He had more instability. He was 37 years, so he underwent an osteotomy along with the ACL reconstruction. You can see that not altered the tibial slope. So doing PCL reconstruction along with HTO was a little more challenging, but in these cases, you don't have to worry about tibial slope because if you have more tibial slope, it will prevent tibia from rolling backwards. That is more beneficial in a PCL deficient knee. And in those cases, in ACL, we place plate as posterior as possible. In these cases, we keep the plate as anterior as possible. And usually, the osteotomy site is where the tunnel comes, so we have to plan the start of the tunnel in the lateral aspect of the tibia. Like in this case, we had a PCL along with the medial compartment OA, chronic. So in this, I use a P plate, and also you can see that my PCL tunnel starts in the lateral aspect. So usually the purpose of when I don't bone graft, I usually keep the non-weight bearing for 2 weeks. From 2 to 6 weeks, depending upon the strength of my fixation, I put partial weight bearing. At 6 weeks, they start full weight bearing. If they are done a ligament reconstruction young patient, they can start recreation sports anywhere from 6 to 9 months, and all activities by 1 year. So, take home message: ACL, high tibial osteotomy or ligament reconstruction is a viable option in young active patients because we restore the normal knee for them. But we have to treat the symptoms. We have to find out what is the ideal symptoms for them, treat them. Proper preoperative planning is very important to get a good outcome, and precise surgical technique, we get good results with combined technique as well.